Every 45 seconds, someone in the United States has a stroke. Stroke or brain attack occurs when a part of the brain is deprived of blood and oxygen, often as a result of a carotid artery blockage. Patients suffering from a blocked carotid artery now have a minimally invasive treatment option. During this live webcast, physicians from Tampa General Hospital in Tampa, Florida, will review a carotid stenting procedure to clean out a blocked artery. They will also answer your questions live as taped highlights are shown.
The carotid stent procedure is one that's taken a while to develop. People that get blockage in their carotid artery in their neck, we're concerned about that because when they reach a significant narrowing of that artery, they have a greater tendency to break plaque off and goes in the brain and gives them a stroke.
For many patients with blocked or narrowed carotid arteries, this procedure is an optimal alternative to open surgery. At any time throughout this program, you may email questions to the physicians by clicking the M-Direct Access button on the screen.
Hello, I'd like to welcome you all here to Tampa General Hospital. We're going to be discussing today carotid artery disease and carotid artery stenting, which is emerging new technology for the treatment of carotid disease. My name is Dr. Bruce Zweibel. I'm an interventional radiologist with Radiology Associates of Tampa. I'm joined here today by Dr. Brad Johnson, a vascular surgeon with the University of South Florida, and Dr. Jim Leffler, who's a neurointerventional radiologist with also with Radiology Associates of Tampa. During the course of the show, we encourage you to submit email questions, and we would plan on answering them during the course of our discussion of this case. And just as a point of fact, it would probably be important for us to explain why this case is not live. We've done live cases before in this particular type of venue, but with these patients, the acuity of their problem actually precludes us from putting somebody on hold for, say, a month or 2 months to schedule a procedure. Usually these procedures, as you'll see today, are a bit more life-threatening and have a bit more acuity to them. So we were forced in this particular case to tape this case live, done live, and today we plan on discussing it with you, showing live video footage from that day of the case and trying to interject some comments as we go through. Best way to start, I think, is to have Dr. Johnson discuss with us today some of the facts that we know about stroke and why it's such a pressing issue today.
Yeah, the main thing that I want to get across in this is that these carotid stents and also the surgery, which I'm going to explain, their main focus is preventing strokes. Some will say, well, they're going to make us smarter because we have more blood supply to our brain. No, it doesn't do that. We only wish it would do that. But the striking stroke facts that we have is that every 45 seconds someone in the United States has a stroke, and 700,000 people a year are going to have their first attack of a stroke, and then we've got 200 recurrent attacks of strokes every year. There's some other things about it. It happens in men and women equally, and the other fact is that African Americans have twice the chance of having a stroke as the Caucasians do. Stroke accounts for 1 in every 15 deaths in the United States. So it is a significant medical problem in the United States. It ranks third among all causes of death behind the diseases of the heart and cancer. And so we're here to talk about a procedure which will prevent those strokes from occurring. On the average, about every 3 minutes, someone dies of a stroke in America, and is the leading cause of serious long-term disability in the United States. If you go to a rehab center or a nursing home, a lot of those people have suffered a stroke, and the cost to our society is tremendous. $53 billion a year is the cost of strokes, direct and indirect. And the carotid artery is unique in the fact that it is the place where most of this plaque will accumulate in a very localized fashion, and these little pieces, as the artery narrows further, are going to break off over time and go into the brain. It's usually observed right at the carotid bifurcation, so it's easily accessed by surgery and also by stents. The standard operation, which we've been doing for 40-something years now, is to go in with an open procedure in the neck and actually remove the plaque, which causes the emboli to break off and causes a stroke. It's an open procedure. It requires an incision, and most people require general anesthesia, even though sometimes it can be done under a cervical block. Carotid stenting is something that's evolved over probably, Dr. Swabel could say, 8 or 10 years. And it's really a step up in technology. As a surgeon who does both the open procedure, the endarterectomy rectum procedure, and the stent procedure, I was a little skeptical at first, but I've become convinced now that this is a way to go for certain patients, and we'll talk about those patients today. The other thing is that it will easily open the artery up, and unlike diseases, everybody in stents in other parts of the body, we've had trouble with stents reclosing, like in the heart and the legs. Well, the disease in the internal carotid is localized to that particular area, and it doesn't spread up the internal carotid artery as other arteries do. So the stent has been really good as far as durability in this particular area. The other things we're going to talk about today with this procedure is local anesthesia in a lot of cases, if you want to. Dr. Swabel is going to bring up and go through, along with Dr. Leffler, is going to talk about the embolic protection device, which is a major advancement because initially before this our stroke rate was about 11%. So we'll go back to Bruce here for this.
The next thing we'd like to show you before we go ahead and begin to demonstrate the procedure and show you some live footage is actually look at some of the instrumentation that's available to us today. Dr. Johnson alluded to the filter device, and actually we've been doing the procedure here at Tampa General Hospital since 1996, and through probably the first 5 years of that time period, there were no filter devices available in the United States, and therefore we had none available here. So we were doing the procedure without a filter, and I'll explain what that filter means in a minute. But the complication rates, although they were extremely low here at Tampa General, nationwide and worldwide, were quite a bit higher than they are today because of this technology. If you focus in here on my hand, you'll see there's and you can come in real tight on my hand, there's a metal scaffolding which I'm spinning right here, and on the top of that metal scaffolding is a covering which is actually thick enough so that pieces of plaque that break off from the carotid artery, which is located in your neck and would normally travel to the brain, are actually caught in the top of this umbrella and don't go to the brain. But there's enough porosity of this so that blood can flow through it and maintain blood flow to the brain. So at no point during the procedure is the brain deprived of blood flow. So you'll see this filter device. We're going to use it today during the case, and you'll see it go up into the carotid artery, and then we're going to retrieve it at the end of the case and take a look inside and see what debris has been retrieved. Now let's take a look at the stent we use, and if you can maybe zoom out, you can get a perspective on just how long this is. Now, the reason...
Not the entire stent.
the stent, as Dr. Johnson said, the stent actually sits in the very tip by my hand over here, and we'll get a close-up of it in a minute, but this is the length of the entire device. This is a deployment device. The reason why it's so long, we actually begin this procedure, and it may seem counterintuitive, but we begin this procedure from the groin area because that artery is extremely accessible to us. It's close to the skin. It's a large artery, and it's one after the procedure is over we can gain control of with our hand and not have to open the patient up. So this actually travels from the groin up into the neck and where it's deployed. If you come down now closely on my hand, I'll show you a little bit about the stent. The tip of this catheter, this gold portion, actually houses, I'll get a profile, actually houses the stent in it. You can see the darker area is the stent. Now, the way this thing works is that and as you can zoom out, when you pull this cartridge back, the outer sheathing of the stent pulls back and therefore deploys the stent. So I'm going to unlock it, and then as I pull this back, you're going to begin to see. Now, if you really get up close on this, you'll see this is the stent deploying, the struts of the stent. It's like almost like a chain link fence wrapped in a ring. And as I pull this membrane back, whoop, now it just took off. There it goes. So here's the stent, and you can really zoom in tight on this. This is actually the stent open. It's made of a metallic material that is such that when it hits the heat of the blood, it expands to a predetermined shape and size and therefore stays open, and the plaque is wallpapered against the wall. Now that I've shown you some of the equipment, we're going to break away to some animation of exactly how this works. I can just borrow that, Brad.
Yeah, sure.
And this is the procedure sort of in an animated way if we focus in on the screen. We've now gone through the blockage, which is this yellow plaque, deployed the filter, which I showed you up here. This artery now goes to the brain. We put a balloon in here to open up and expand the plaque so that our stent will fit. Little pieces may break off and are now trapped in the filter. We now put the stent in, retract that membrane, the stent is deployed. We next pull the stent material out. We next bring in the balloon, open up the stent to its maximum diameter, therefore wallpapering the plaque against the wall. More pieces may break off at that time, get captured by the filter, not go to the brain. We now retrieve the filter, take it out, stent stays in place, and there's brisk flow to the brain. We're now going to have Dr. Johnson talk to us a little bit further about the procedure, and we're going to break into some of the live footage.
Okay. As Dr. Swabell mentioned, the reason we come, everybody always asks, why do you go from the groin? Well, like he said, the femoral artery is the easiest to access, and we've been doing accessing the femoral artery for many years. And so the procedure itself, what we do is we usually will give a little local anesthesia, we'll prep up the groin, and then from there we'll take a needle and access into the artery and then place a guide wire followed by a catheter down into the femoral artery. And from there we're going to thread this all the way up into the carotid artery from here. Bruce, you want to?
Yeah, we're going to now break into some live footage. I want, before we do that, though, I just want to encourage anybody out there who has questions about this procedure or really anything involving this type of disease to please email us questions, and we'll go over them during the broadcast. We're going to break away to some footage, and we can look at this screen here. This is a case that we performed about a week ago, and Dr. Leffler is going to take us through some of the things going on here.
And this is where we have already prepped the right groin, and we're gaining access into the femoral artery in the groin with a needle. Once we gain access with the needle, we pass a wire, and over that wire we pass that small tube that's a catheter into the right groin to give us access to the vascular tree of the body, essentially primarily the aorta, but after that we use it to get into the head vessels.
Just as a question, Jim, when we looked at the wire and catheter going in, are there any considerations in terms of, what type of patient anatomy is favorable, what type is not favorable for this type of procedure? Maybe you can cover some of that.
Of course, the more favorable patients are those patients that don't have atherosclerotic disease in their legs or thinner patients, because you have easier access to the femoral artery. However, there's usually very little patients that we cannot access in the groin.
So basically, there's really no limitations for access.
Correct.
Okay, I don't know if there's any email questions that came through, or we can continue on with the footage. Perhaps maybe we'll go to the next segment of footage here, and we're going to begin to move into the procedure a little bit further. We've now introduced the wire and the catheter. Now you can tell us what we're doing here, Jim.
We're have the catheter in the groin and up into the neck vessel. We're trying to pass a wire to try and get into his right carotid to have the catheter pass over the wire and give us access to the carotid artery, right where the red dot and highlighter is. Once we've achieved access in the right carotid artery, then we can image the right carotid artery and do some measurements to try and figure out which stent is the right size stent for the lesion and what the lesion actually looks like.
So here we're actually injecting dye through the catheter that we had introduced into the neck artery. And on these screens are the pictures that we're taking. You begin to see them right here and here. They're actually pictures of the neck, and we'll begin to see some of the blockage. Maybe you want to comment. I'll put my pointer on where the disease is, Jim.
Yeah, that's the fork in the vessel down low is where the common carotid artery sits in the neck, and the common carotid artery has two branches, one that goes to the face vessel, another one that is called the external carotid artery, and then the other one called the internal carotid artery, which goes to the head, and that one has the area of stenosis. And then what we also do is we image over the head image over the vessels of the head before we put the stent in to make sure which vessels are open and which vessels are potentially
closed. So this is actually the patient's brain, and it's very important for us to image the brain, because in fact what we're trying to prevent here is a stroke, and we want to make sure that the distribution of arterial supply that we're now going to open doesn't have any problems that's further ahead than we're fixing, and also make sure that we know exactly what vessels are patent before we start, so that when we finish the procedure we know if any of them are missing. I think that's important to know. Just if there's any email questions that came through, we can take them if somebody.
Bruce, we might bring up one thing here, is the fact that a lot of people say, well, why haven't we heard of this? Well, as you and I well know, it took a long time to learn how to do this, and there's only certain places that are approved, and you can talk more about the approval process and who gets stents and so forth.
Yeah, I think it's important to know that, and I guess one of the reasons why we're trying to bring this out to the public is that we've been doing this procedure here at Tampa General, like I said, since 1996. It actually is what I would consider to be a new procedure these days. Medicare has just approved the procedure about a year and a half ago. So there are many centers throughout the United States who are now trying to gain experience and who are trying to learn how to do the procedure. I think that if there's any procedure, and you two might want to jump in on this, that if there's any procedure where experience is an important predictor of success, I think this is one of them. And certainly places like Tampa General, where we've done nearly 300 carotid stents, is extremely important in terms of success. Now, the other issue is complications. You want to technically be able to do the procedure, but you also want to have very few complications, and that's one of the things. Our complication rate here is well below the national average for stroke and other such complications as it relates to this procedure, and that's even including probably half of our stents were done without any type of filter or carotid protection. We now have a couple of questions that came in, and maybe, let's see. Now, somebody commented that an MRI indicates that my left carotid artery is 100% blocked. The blockage where the artery, the blockage exists as it exits the heart. Can the stent procedure be used to open the artery? So I think what the patient is referring to here is that the artery out of the heart is probably not exactly out of the heart. It probably comes off the aorta, which comes off the heart and then eventually goes to the brain. And their artery, their carotid artery, is 100% blocked. In that type of scenario, we can't open that vessel up and effectively provide blood flow. But maybe Brad or Jim, you want to comment on what the stroke rate is with somebody with 100% occlusion?
Sometimes the MRI will overestimate the degree of stenosis, and therefore a 100% blockage on MRI may not be 100% blocked. And if there is a small channel that we can get through, we could potentially treat that. But in addition, if it's been proven by other studies as well that it's 100% blocked, then it likely is 100% blocked.
Yeah, and the thing you have to remember that is once an artery completely blocks, there's no blood supply going up into the brain, and all the strokes are caused by not lack of blood supply actually from that particular area. They're caused by pieces of plaque breaking off and then traveling to the brain. So if you're already 100% occluded, no blood is flowing through that artery, so you don't have to worry about having a stroke from that plaque anymore. So you don't need to be fixed. Initially, when we first started doing carotid endarterectomy, the open surgery, we actually did some patients who were completely occluded, and the outcomes were worse, and so we quit doing that. So if you are completely obstructed 100%, then this lesion should be left alone. No surgery or no stenting for this lesion.
Before we get back to the case, I think there was another question that came in that I think is fairly interesting. Somebody was saying that they had pain when they turned their head, and they had pain on the side of their neck. Could that be due to a blockage of the carotid artery? And I think it's important for people to know that in all likelihood that's not related to carotid artery disease. The time that the carotid disease is evident is usually at the time of either strokes or mini strokes, however you want to call it, where somebody has some depleted blood flow to the brain. So typically pain is not a predictor of carotid artery disease. It's usually a predictor of other types of things like musculoskeletal problems and other things.
Yeah, most people will not experience any symptoms before they have a stroke,
Right.
And that's the reason we always have to look at risk factors. And risk factors will say, okay, by the way, somebody's got hypertension, somebody smokes, somebody has hypercholesterolemia, and those people need to get an ultrasound of their neck to check for stenosis because, especially when we reach the age of 60 or 65, those factors will weigh in. Get an ultrasound, and that's one of the most accurate ways to determine if you have a blockage or a narrowing of your artery in your neck.
I think probably the best thing to do would be let's break away to the next segment, and we'll pick up some more questions as we go along. But let's grab the next segment. And what we're doing here is the vessel's been imaged. Jim, you could talk about the measuring and whatnot of the carotid artery.
What we're doing here is we're measuring the size of the carotid artery as well as the size of both the internal carotid and the common carotid, and the length of the area to be stented, because the stents come in different sizes and shapes, and we're trying to match the exact size of the carotid with the most appropriate stent.
I think it's important to also note as we're doing this that this is the patient's neck, just to give you some. This is the jaw. This is actually a wire coming up from below, and we're to the part of the artery that supplies the face that we were talking about earlier, not the bring our system into place so that we can actually start the carotid stenting procedure. So this wire, which is marked all the way down here, is actually going up the external carotid artery and allows us to anchor ourselves so that we can bring our sheath system up into place. I think another question came up, which is kind of interesting. Somebody in the audience asked about the fact that their daughter had a spontaneous carotid dissection and a blockage in their carotid artery. And I think that brings up the point of what type of patients are we dealing with. Brad, you alluded to patients who have atherosclerotic disease and others, but there are other people who can have carotid artery disease.
Yes, there's different types of disease. The most common one is one we're treating today, which is when people develop plaque disease as we get older from those risk factors I mentioned before. Another disease that occurs in the carotid artery is fibromuscular dysplasia, which happens in women and happens in their 40s, and it's just an abnormality. Not seen that common, though. And then for some reason, some people will have a dissection. And what a dissection is basically your artery has 3 different layers. And for some reason, the blood will create a hole through the first layer and will separate the layers up. And we see that. It's not a very common thing, but when we do see it, a lot of times it will create symptoms. And the treatment for that, the majority of the time, is just to thin your blood out. And that actually works very good in most people. And then we search for, is there an underlying reason why that spontaneous dissection occurred? Does this patient have fibromuscular dysplasia? Do they have hypertension out of control? But today we're going to be more focused on the plaque disease that develops in people.
But I think, and Jim, you might want to comment that patients who have carotid dissection can also be stent candidates. Mm-hmm. It's just a different disease process, and maybe you want to comment on that, Jim.
Usually what we like to do is we like to, as Dr. Johnson said, treat them with anticoagulation or blood thinning first, and if after a certain period of time that their dissection persists and the narrowing persists, then we go ahead and decide to stent it if it's a hemodynamically significant lesion at that time. The other thing is sometimes the dissections we get emergent on an emergent basis, and if at that time that it's significantly hemodynamic and the patients are symptomatic, we may go ahead and stent it at that time more urgently versus waiting at a later time.
And that's been, like you said, one of the major advantages. The surgery would not work. A stent was the only thing, surgery when we tried to operate on these people, most of them we actually harmed. Mm-hmm. So surgery is not an option in the majority of dissection. So it's been great that now we have a system we can use for these people.
And the other thing at Tampa General, which I guess we probably see more trauma than most medical centers in this area. We've had a number of patients who have sustained motor vehicle accidents or other high-velocity type injuries who might dissect the carotid artery. And those patients are typically young. Some of them come in and have strokes after they've been in the hospital for a short amount of time, or some people come in with a stroke. And those people are also ones that we've put carotid stents into. So I think this technology, although we feel like it's most appropriate for people with atherosclerotic disease, it does have other implications and other indications. I think it'd be a good idea if we could break away to the next segment of the case, and we're going to sort of bring you along. What we've got here is our sheath, and then Jim, you want to talk about the filter, maybe?
Yes, we have the sheath, which is our platform to perform the carotid stent, with the sheath tip going all the way from the groin into the carotid artery below the stenosis. And then what we're doing now is we are trying to let some of the backflow of the blood, so we don't get clots up into the head. But then after that, what we try and do is we try and pass a small wire, which is a small filter wire that is collapsed on itself, which is the filter wire that Dr. Zweibel showed, through the area of stenosis and then distal to the area of stenosis. And then we open up the filter wire and use the filter wire for two reasons. One, to try and catch any sort of plaque as we perform the remainder of the procedure, and number two, as a guide for our balloon and stent to go into.
I think one of the things we want to comment on is the operator's left hand is on the sheath. Now that sheath is a cylindrical tube that's been introduced into the carotid artery already. That's what we had our wire showing on the previous set of pictures. So that is a direct line to the blockage, and this filter wire is now being introduced. And pretty soon we're going to see that filter wire kind of snake through the blockage up into the brain. Here we see it right here, live footage of the. It's now poking through. We're negotiating it through that blockage, and here you see the tip of the wire coming up. And Jim, you want to maybe take it through there?
Yeah, the tip of the wire is actually in the distal internal carotid that has already been passed through the stenosis, and you can see that little dot right in the center of the screen with the that's on the filter wire, and then we are going to unsheath the filter wire to deploy the filter basket, so it will be able to catch any sort of plaque that potentially gets dislodged. And there is a close-up magnet view of the filter, and there it just got deployed. You could see the prongs of the filter wire just opened up, and now the filter wire is open and the basket is open, and now we are in the next segment of trying to try and do this procedure.
I think it'd be a good idea. There's a couple of more questions that came through via email, and many questions have been coming in about the symptoms of stroke. I think maybe one of you two want to cover again what things people will be concerned about.
Yeah, we hear, a lot of people come to see me about when they'll pass out or they'll be dizzy, and these are not the symptoms of stroke. They're pretty specific. We got to remember what is occurring is a piece of plaque is breaking off and going into your brain. So, for instance, the right side of your brain controls the left side of your body. So what will happen when a piece breaks off, it's going to go up into your brain and cause the left side to either go completely paralyzed and you won't be able to move it, or it goes numb. And if you have a minor stroke or TIA, then that's going to return to normal in an hour, a couple hours. But that is a serious sign that you're going to have a major stroke. And then the other thing that can happen, if a tiny piece breaks off, it actually can go to the back of the eye, and people will tell you it feels like the gray shade got pulled over one eye. And it's never both. It's always just one, because a lot of people come in and say, well, I'm having blurry vision. Well, blurry vision isn't a sign of a piece breaking off and going into the back of the eye. It's usually just the gray shade being pulled over the eye.
So I think one of the main points I think you'll both agree is that if you have any of these TIA, which you mentioned, which is transient ischemic attack, which is sort of what some people call a mini stroke, those are some of the greatest warning signs that you're at risk for having a major stroke. So if you have any of those type of symptoms that are fleeting, that if you have a paralysis or a numbness or a visual problem that comes and goes, then we would urge you to quickly go see a physician. That's a very serious problem.
Bruce, do you want me to show them the PowerPoint thing? Right. We'll do that. One thing that is really, like Bruce mentioned, has been a great investment. When we first started doing this at Tampa General, was we didn't have a filter, and when pieces would break off, your stroke rate would go up. But kind of thanks to the university and also Tampa General for allowing us to pursue this in the face of that, and also the companies who probably like Guyton, who developed these filters because it's been a major advancement as far as protecting the brain when we do these procedures. So basically the filter is collapsed down, taken across the artery of the narrowing of the artery, and then reopened. And as Jim will probably show you in the next slide, that artery up there where the filter is completely normal, and all that disease is localized down to the bifurcation. And the thing we're going to do here soon, which is we're going to take a balloon and go in and open that lesion up, and that's going to allow us to place the stent through there safely, because that filter that we have is a very fine wire, very tiny, and it can get through most of those lesions without any trouble. So I have to emphasize that this technology has been a major advancement, which allows us to do this safely now compared probably to 5 or 6 years ago.
I think one of the other slides you have in the PowerPoint is with regard to pre-dilating. We saw in the animation earlier that a balloon was placed before the stent to open up the plaque in order for us to introduce the stent. And I think some of the blockages are so tight that we can't even fit things as small as I was showing you earlier through them. So we have to what we call pre-dilate, open them up ahead of time so that we can have at least a conduit to introduce our stent. So let's break away. We'll get the next segment underway. We're kind of getting to the meat of the action, and we could talk about pre-dilatation, Jim, and the stent.
Yes, and this is us centered over where we already have the filter wire in place, and we're passing a balloon over the wire through the sheath, and then we're going to continue to advance this balloon up to where the area of narrowing is, and once we put the balloon across this area of narrowing, we're going to inflate the balloon, as Dr. Zweibel said, to try and create a conduit so we can deliver the stent across the lesion. And the reason why we do this is the stent delivery system is a lot thicker than the channel of which you are going to pass through the carotid artery. So that's in the area of stenosis. So that's why it's important to pre-dilate. And here, it's good that we already have the filter wire in place, because as we pre-dilate, some particles can break off, and the filter wire basket will potentially capture some of those particles. And this is us advancing the balloon in the groin. However, remember that as we advance in the groin, we are watching the screen and watching the balloon cross the lesion.
I think we can see it come up now. There's a
and
marker.
You can see it just track up now. And as it tracks up, we inflated it to get a good pre-dilatation to try before we place the stent.
We've been getting some email questions, and I think this would be a good time to cover it, about, how long does a stent last? Does it collapse? Things about the durability. Brad, you alluded to the durability of stents a little bit earlier.
Because, a lot of patients will ask me, I work at the Veterans Hospital too, and they're concerned because they've had heart stents placed, and they've had 2 or 3, and they have to go back in and get it ballooned, or then they have the stent collapse down, and they have to go to surgery. And that was the skepticism amongst surgeons in the beginning. We thought, well, God, here we are, this thing's going to collapse down, and we're going to have a lot of people having strokes. But it hasn't proven to be, because, like I mentioned, the carotid artery of the disease is very focal, and the rate of restenosis is 5% or less. And it's so easy to treat the restenosis. We don't operate on you. We don't remove the stent. We just put a balloon back up there and reopen the stent again, and that works perfect. And so this location, I guess, is the key to this, and the fact that we just haven't had that many people come to surgery. I mean, like probably 1 out of every 1,000 patients has had to have surgery after having a stent put in.
Yeah, I think this distribution of between, it's a very high flow area, and you alluded to, Brad, earlier, that it's very focal, very localized disease. So I think it's different than other parts of the body that we stent. Mm-hmm. I was almost chuckling to myself. There was a couple of emails that came through, and they were asking who actually does the procedure, which it actually is us in the video. We're not just doing the narration. And I think that brings up a good point, that we have a multidisciplinary team here at Tampa General, which we feel gives patients the best possible opportunity for the best possible outcome. And by that I mean there are some patients who are just poor candidates for surgery. Right. There are others who are poor candidates for stenting. So you really need a program where you have the very best of both abilities, and I think that's what we have here at Tampa General. Just to supplement that just a little bit, there's a trial that's going on in the United States sponsored by the NIH called the CREST trial. And it's a trial where they're looking at randomizing patients for surgery versus stenting to actually see which is the best procedure, if there is a best procedure, and where is the surgery or where is the stent best used in what type of scenarios. Because we have both types of expertise here at this hospital, we've been selected. We're one of a number of sites in the United States who have been selected for this trial, and we're enrolling patients whenever possible to try to gather that information.
Yeah, there's some certain subsets of patients who we know stenting is better, people that have had terrible heart disease or lung disease, who can't undergo an open operation, and people that have radiated necks. But then on the other hand, there are some people that probably should not get a stent. That's what the CREST trial is going to answer for us. It's going to determine which people. And so it's a very important trial because it's government run. It has no bias. Another thing that Bruce mentioned, that we've always worked here together. I'm a vascular surgeon and an interventional radiologist. We have a conference together once a week, and we go through all these cases with a group of surgeons, maybe 8 or 10. We got residents and students, interventional radiologists, and we make decisions on a collective basis. And that way, always 20 minds is better than one mind. And by doing that, that's, I think, been one of the major reasons that we've been successful at Tampa General, along with the University of South Florida, in establishing programs like the Carotid Stent program and the endovascular AAA aneurysm program.
This is actually a good segue. We've been getting a number of questions about, have the filters in place, now how do you get it out and things like that. So I think what we ought to do here is maybe break to the next segment of the case, and just to bring you back up to speed on what we've done so far. We've got the filter wire up in the internal carotid artery. We've got the balloon angioplasty to get the stent in place, and now we're actually introducing the stent. Jim, you want to tell them?
That's what we're focused in right there. The little gray square is the actual stent delivery system. We've crossed the lesion with the stent in place, and we're about to deliver it. You can see my hand right there. About to deliver the stent. Those two prongs on either side, as I'm sliding it back, is delivering the stent and opening up the stent and laying it in the carotid artery. And what we're doing now is we're looking on the screen as it was deployed to make sure that where it is and what location it is and how it was done. And now we're about ready to pull the stent delivery system out. But you can see the stent delivery system track up. This is before we deployed it. The little two dots there crossing the lesion, and there's the stent. After it's deployed, you can see the metal, the faint metal outline of the stent in front of those vertebral bodies, and you have distally where the wire is through the lesion and with the filter wire above the stent.
I think at this point we're going to go back to some of the slides, and Brad, maybe you can take people through some of the stent deployment.
Yeah, first we had pre-dilatation in order to get the stent in there, and then after that, as Jim just alluded to, we placed the stent across that lesion, and we try to get into normal artery distally and normal artery proximally, and that stent opposes against the arterial wall and keeps plaque from breaking off and going up into the brain. And then after we do that, there's sometimes some residual narrowing. The stent has a radial force, as Bruce mentioned earlier, that it expands until it hits something, but then sometimes it's not strong enough to push that that calcific hard plaque off. And so after that, we'll come back in with a balloon and gently open that stent up a little bit further, so we have a good anatomical and physiological result from that.
Just before we get further along, there have also been a number of questions about stroke, the use of medicines to dissolve clot in the brain, and there have been a couple of questions about stroke teams. I think it's important for us as a group here to comment that Tampa General is one of the few centers in the state that has a complete stroke program. Jim, maybe you can talk about comprehensive stroke centers.
Yes, as a neurointerventional radiologist, I deal with a lot of the vessels of the head, and Tampa General is one of those few centers in the state of Florida, as Dr. Weibel said.
You know how many?
That I think there's 3 other comprehensive stroke centers in the entire state of Florida, but those comprehensive stroke centers have to meet very specific criteria on having certain people on staff to make sure that if someone does come in with a stroke, that it can be treated at an appropriate time and at an appropriate level, and that's another reason why it's somewhat good to have procedures done here at Tampa General for the main reason that.
What time period do they have, Jim?
Usually for a acute stroke in the front circulation of the brain, called the anterior circulation, you have up to 6 hours. Really, it's up to 3 hours for intravenous tissue plasminogen activator, which is the clot-busting drug, and up to 6 hours to try and give it through the arteries of the neck and head from a groin access, sort of how we're doing the carotid stent. We have a very excellent stroke service at Tampa General that does cover a lot of the acute strokes that do come in, and we have all the devices at Tampa General necessary to try and open up vessels inside the head, some of which are FDA approved and some of which are not. However, we try and appropriately treat those patients that come in with an acute stroke in the appropriate manner that they need to be treated.
I think it's probably worthwhile to mention that we've been talking today about carotid artery disease. That's one element of stroke. As Brad showed the slide earlier, maybe 10, 20, 30%, maybe 25% of strokes occur as a result of carotid disease, but really stroke, carotid disease is all lumped into a big category of neurovascular care. And I think one of the things here at Tampa General is again, it highlights the multidisciplinary nature of disease treatment, which really is not something that's available in every hospital. And Brad, I know you talked about it a little bit about our interaction, but I think globally that's an important thing. When patients come in, to me, I think it's very important to have the resources of multiple different departments and expertise across the board.
Yeah, and I think it keeps you honest too, because you're not by yourself working. You're working as a group. In groups, especially surgeons and radiologists, can be pretty critical of each other, and so if you're doing something which that people don't believe is right or isn't good for the patient, there's usually somebody will tell you to do it the other way, or you're doing it the wrong way. And so that's been good. Plus, we're with the university system here, and the University of South Florida, and therefore we're always checking our results. We publish papers on this, and our chief of vascular surgery here is the editor of the Endovascular Journal, and so you have a lot of expertise here. It surprises people when I tell them, by the way, that the editor of the Vascular Journal is in Tampa at the University of South Florida and at Tampa General Hospital, because people just don't realize that exists in this town.
I think that's a really good point. For me personally, I've been here 15 years, and to think we've probably done more carotid stenting here at Tampa General than just about any institution in the state. Maybe one or two have done more, about the same. So, and I think if you look at our results, it's something to be proud of. And people here in Tampa, and maybe people here in the state of Florida, might not realize the resource and the value that comes with having this multidisciplinary approach. Just to jump ahead, there's been a couple of questions, matter of fact, on the same topic, which is, I guess there are some people out in the audience who know that they have blockages above the point we're talking about. So in other words, most carotid artery disease occurs at the branch point of the main carotid artery. There are some people who are emailing questions that they, with a fair amount of sophisticated knowledge, that there's blockages higher up in their artery at the skull base in the brain. Jim, you maybe want to comment on some of that.
Since I treat a lot of the head and neck vessels, basically you can have stenosis higher up in the head vessels, although it is somewhat different than the neck vessels. If you do have stenosis or narrowing in those head vessels, some can be amenable to medical therapy, some can be amenable to using a balloon or angioplasty, and some can be amenable to using a small, low-profile stent that is different than the stent that we're talking about today, but these lesions can be treated by endovascular as well as medical. And then one thing about Tampa General that we have is we have a very good neurosurgical team that if stenting or medical therapy fails and it needs to be still fixed, or if the vessel is occluded, sometimes the neurosurgical team can do a bypass that will help give more blood supply to the brain. But these are only in indicated patients, and that's the good thing about our hospital, is that we all work as a team and we try and figure out what procedure is best for what patient. And those vessels of the head are a little bit more special because the risks of stenting or angioplasty or doing anything when you get higher up in the head go significantly higher.
Yeah, there's only, 3 or 4 places in Florida or so that do stenting in the brain?
There's only three other places in the state of Florida that usually do the degree of endovascular stenting of the head vessels that Tampa General does, or more specifically that I do. But
I think it'd be a great opportunity for us to break into the next segment of the case. Right now, I guess we've dropped off the stent as we deployed it as before. Now we're picking it up. Jim, why don't you take us through?
Here, the next process after deploying the stent, as Dr. Johnson had alluded to, was sometimes the stent doesn't have enough radial force to open that vessel up completely. So what we try and do after the stent has been deployed is to try and get the stent fully opposed to the wall where the area of narrowing is, and try and open up that vessel to a better extent than the stent has the ability to. And it's called post-dilation, and we usually use a very trackable balloon that rails over the stent, rails over the filter wire that is still in place. And you can see Dr. Zweibel here advancing it over the wire. As we're watching the screen, we're holding the wire or pinning the wire in place and driving the balloon up across the lesion that has the stent already in place, and we are going to navigate that balloon or watch that balloon go across that lesion. And this is an insufflator device that we use to open up the balloon. You can see that the dial is going to turn in a clockwise direction as we turn down on the insufflator and inflate the balloon. We do it very slowly because you don't want to all of a sudden jam a balloon in a place that it doesn't need to be in. There you can see the balloon within the stent. It's already opened up the bottom edge of the stent where it had that stenosis and reestablished flow, and then we quickly pull the pressure down off the balloon and then remove the balloon out of the body while still holding the filter wire in place. And the important point here is that the filter wire is still up, and any debris that could have been washed out would have been hopefully caught by the filter wire.
That brings up a good point. Now that we've seen the stent deployed and we've wallpapered it up against the wall, if you will, a couple of questions came in via email. Brad, you might want to talk about this. Now that the stent's in place, can it move? If I turn my head, there's been a bunch of scenarios depicted. Maybe you can comment on.
Yeah, usually the nice things about these stents and the newer technology, and that's the reason that if you look at some of the initial studies with placing stents, and we were involved in them, the technology was one of my former professors says, you're working with a medieval instrument here, and we finally come into modern times, and these stents are going to keep expanding until they oppose a wall. So I've not say never, because never it's something that's happened, but most of the time these stents, they just don't move. You can turn your head, you can get in a car wreck, you can get hit playing football or something, and the stent will stay in the same place. So that hasn't been any concern for us.
A couple other good questions came through that I think we need to cover. Is some patients out there are talking about they've had coronary stents placed in the heart, and they have known high cholesterol and other risk factors for disease. Again, either one of you want to comment about, they've been asking, well, what's my risk of having carotid artery disease?
Yeah, they correlate. When I'm teaching students and residents, I tell them, what's the most statistically significant thing about it when you have when you can hear a noise in the carotid artery. Well, the most important thing about that is that means that you got a 30% chance of having significant disease in your heart blood vessels. So the same kind of thing works with coronary, with heart vessels. If you have heart vessel disease, then you should have a duplex scan of your carotid artery in order to see if you've got disease there. And so these people at high risk, these people with hypertension and these people with high cholesterol and stuff, those people really need to be screened with carotid duplex scans or the ultrasound, same thing, in order to determine what degree of stenosis they have.
And I think, that you mentioned screening, it brings up a very good point, because there's a number of ways to get screened out there today. There's trucks that come into neighborhoods that screen. There's all sorts of things you can have at the mall. I think my personal feeling is, and it's easy for us to say sitting here, but if you're a high-risk patient, that's not where you want to get yourself screened. Am I right?
Screening is good. Some of the ones that go to the mall, at least they are. We've been slow to educate the public about carotid disease, and at least they wake the public up. But it's not an accredited lab, and therefore, if you do have a positive result with that, then you need to go to an accredited vascular lab or to an accredited hospital and make sure you get an accurate, because that test of the carotid ultrasound is technology dependent. It's a technician who does it, and if they make a mistake or the reader makes a mistake, you could go to have a stent placed for some unnecessary reason. And again, it comes to the fact of what we have here. Dr. Dennis Bannock is professor here and chair of surgery, and he's on the accreditation board for those vascular labs. And so there's actually an accreditation symbol that will be on the side of their reading or in their place where they work, and it'll tell you if the lab's accredited or not. And those labs you can trust. And the other thing is, you don't need a angiogram to determine carotid disease. You don't need a CT scan. The carotid ultrasound is just as accurate, especially. The reason we have angiograms is to plan and do these procedures, whereas the carotid ultrasound, actually, when I do them, 95% of the open surgeries for carotid are done just based upon that carotid ultrasound. So we don't need all this fancy technology because we have good testing in accredited labs, which is important.
I think that's a good point, and as a radiologist, I'd like to make a comment that it is true that in days prior we had ultrasound where even that technology is improved, and we had angiograms, but today we really, there is a risk of an angiogram. There's a stroke rate associated with angiograms, albeit low. But now we have, with the advent of CT angiography, we can essentially get images that are as good or better than an angiogram in an outpatient setting through an IV injection in the arm, essentially no risk. So I think if anybody has disease, and they need to make sure they're affiliated with a center or seeing physicians that are up with the newest technology in terms of imaging.
Right. You want me to share the PowerPoint slides?
That'd be great.
Jim went through, we removed this filter, so what we do basically is collapse this filter back down after we've put the stent in. And so we collapse it back down into a catheter, pull it out, and then the next thing you do, we will open it out on the table to see. And as you can see from this PowerPoint slide, the debris that was collected in this filter. And you can imagine if this debris would have gone into the brain, then this patient would have had either a mini stroke or a major stroke. So before the technology was invented for these filters, that's the reason the stroke rate on some of the initial trials was 11% for a carotid stent procedure. Well, that's come down. That's like in most across the country, maybe 2 to 5%. And I hate to brag, but Dr. Saubel can tell you here our stroke rate is probably 1% or less. That's right. Carotid stent placement. So I think that the technology's come along, and we've learned a lot in the time that we've done this. In the case, this is just a case example here I have up on PowerPoint, and basically this shows the lesion before the stent, and here is the lesion after the stent. You can see the entire system now appears normal. And this, so far, we've only been doing this for 8 or 9 years now, but this durability is lasting years and years. And I expect it to last, patients that are 60, hopefully when they're 90, the stent will still be working, which I expect it will.
I think that, that brings up another good point is we've had a number of email questions about what are the risks of the procedure. And I would say, you mentioned stroke. Obviously, stroke is the biggest risk of the procedure. And here we're doing a procedure to prevent stroke. We obviously don't want to give somebody a stroke during the procedure. Our stroke rate here at this hospital is about 1%, and like I said, we've done nearly 300 cases. The national average for stroke for carotid stenting varies, but it's anywhere from 2.5% to as high as 10%, depending on the institution and the trial. So we're incredibly less than the national average, if you will. And I don't know, Jim, you want to talk about any issues with regard to technique and things like that as it pertains to stroke rate?
Of course, one of the things that drives up in some of the most recent studies of stroke rate is during a carotid stent is advanced age of a patient. And the older the patient is, the stroke rate in some of the new published data has been all the way up to 10% in patients that are 80 years old. But as patients are 50, 60, and 70 years old, the stroke rate significantly is diminished. And that's where you hear the term octogenarians, and a lot of people that are asymptomatic that are 80 years old that do not have that high of a stenosis. The risk of doing the procedure is a lot higher. But some patients that are 80 years old need to be done, and those are the ones that we carefully weigh and that we say, well, this is significant enough for us to treat. The other thing that we have at Tampa General that's a little bit better is that the longer time that you're in doing the procedure, the higher risk of having a stroke. And the reason that is as you have all this hardware, as you're deploying up there and taking more time, then there's more chance for the body to actually clot off that area or send a clot up to the head vessel. And we at Tampa General have basically narrowed this procedure down to, while we're stenting, to about 15 to 20, 25 minutes at most. Because we have done so many, we actually anticipate each other's moves the entire way, so it makes us a lot faster in the procedure. Plus, we also have a lot of experience in doing carotid angios. This hospital, being that it's a primary stroke center and being that a lot of patients come in that need cerebral angiograms for other reasons, we have gained a lot of experience in doing the cerebral angiograms that a lot of other centers are probably 1/5 or 1/6 as busy.
Yeah, I don't want to scare the 80-year-olds away, because I think the problem with those studies is they're not selecting patients right. I mean, because we haven't had that many strokes in 80 years. And that's the reason the CREST trial is going to be so important, because it's going to tell us, when we randomize these patients over 80 to stent surgery, it's going to help us to pick out which 80-year-olds is it safe for us to do stenting. Because, the ideal patient is going to be the older patient who doesn't want to have an open procedure. So somebody had a question about, are these mobile labs that go around accredited? Again, I don't want to knock the mobile labs, because they're doing something that we are unable to offer now, which is getting this out to the public. And if they detect a lesion, that's great, because most of them are not accredited, but at least you're going to know that you need to go get something checked. So that's, even though they're not accredited, they're doing a service in the community to at least determine which patients are at risk, and then those patients can come into an accredited lab. And that's what we do. I have a bunch of patients that come to me, and they've had the mobile lab do a study, and we just repeat it just to make sure that everything is accurate.
This would be a good time. We're going to break through to the next and I believe final segment of the case. We've retrieved the filter, and now you can see some of the debris within the fingers pointing to some of the debris within the filter. And this is the final angiogram. We're seeing there's a front view and a side view, and you can see, we're going to have a close-up here, but you can see how the previously narrowed area is now smoothly lined and is widely open. So I think, obviously we don't have the pre and post next to each other, but you can see that blood vessels is widely open. To finish the procedure, there's also a need to look at the brain when we're done. We always do that to make sure that there's been no pieces of plaque that go to the brain, and that kind of completes the procedure. One thing about the procedure, there's been some question asked about, how long does the procedure take and things like that, about patients coming in and out of the hospital, how long can they expect to be there, things like that.
I think nowadays, it used to be we always admitted people the day before, had an angiogram one day and then the next. And sometimes we still have to do that. I mean, some people are complicated, and we don't have the the information we need prior to putting the stent in. So they end up spending a day getting the angiogram, the next day getting the stent, then the following morning they go home. And then some people, if we have good imaging ahead of time, a good CT angio or everything, and we're sure that what type of lesion we have, then we might be able to admit them that day, do a carotid stent, and have them go home the next day. Again, has that been your thoughts with the Jim?
If they've got, as Dr. Johnson said, if they've got good imaging before, if they've had an angiogram somewhere else, and we know what we're treating, usually we could do the stent that morning. And as soon as we finish the procedure, the patient will usually stay in a ICU bed overnight or a step-down unit overnight, and then by the next morning, they are, of course, hopefully back to normal. And by the next afternoon, they're usually gone. And they're pretty happy that the only little thing they have as a remnant of their procedure is a little nick in the groin, no bigger than the size of a pen.
Well, just to borrow an expression from my colleague Brad, we want to thank you all for watching our show. This concludes our hour with you all. I'd like to give special thanks to a few people. Number one, Tampa General, for allowing us to practice in this environment, to give us the equipment that we need to do what we have to do. Thanks to USF for providing an educational environment and a place where we can really push technology forward, and to Radiology Associates of Tampa to allow us to do what we do. Also, a thanks to Guidant for their equipment here today, and a device we use quite frequently here. I would encourage you all to watch the archive show. It'll be ready in an hour, they told me. So if there are any other questions, there should be forwarding numbers. What's that?
You better thank Pat for helping us.
And Pat. Pat Conan. And if there's any questions that come up, feel free to call Tampa General, our office. We'll be happy to answer them. Again, thank you for watching the show.
This has been a live webcast panel discussion of a carotid stent procedure from Tampa General Hospital in Tampa, Florida. For more information, to make a referral or make an appointment, click the buttons on your screen.